I'm going to talk about another sort of cousin in the verbal autopsy family. This one's called VAPAR, Verbal Autopsy with Participatory Action Research. This is a report on the development of a methodology. So there's some results to report, but this is mostly about the process of developing a people-centred, action-oriented method in South Africa. There are three main phases to this method that I'll talk through. Firstly, as we've heard already today, VA is a method to understand the medical causes, levels of deaths, but I think as illustrated very nicely in the preceding talk by Karen, VA might also be an opportunity to look at critical limiting factors that occur in terms of the circumstances and events at and around the time of death. And then the idea was to take these extended renditions of cause and circumstance of mortality and further verify and amplify them using a participatory process, PAR, Participatory Action Research, to gain local knowledge, not only on what causes or contributes to these conditions, but what can be done about them. And then all the way through, but formally at the end, we sought to embed the process in the health system in order to do research of a practical relevance, very much going back to the action orientation. So the work was done in South Africa. South Africa, obviously, middle-income country, 55 million people, devastated in some ways by HIV. There's often a quadruple burden of disease noted in South Africa of communicable and non-communicable diseases, maternal and child mortality, and mortality owing to external causes, violence and assault, and so on. In spite of this, the policy context in South Africa is interesting. It's progressive, inclusive, enshrines the right to health in the Constitution, and community participation is seen as an integral part of primary healthcare, but there's a well-recognised divide between policy and its implementation. Something falls off in the implementation, the coming to life of policy. This is an image from the rural province that the work was done in, up in the northeast on the border with Mozambique. This is Mpumalanga province of 4 million. A lot of unemployment, a lot of poverty. Large burden and largely inequitably distributed burden of HIV. And it was a field site up in the northeast that we worked with, a DSS site, a demographic surveillance site, that really made it possible to work through these three steps that I'll describe in a bit more detail. So this is obviously not a picture from South Africa. This is a picture from Indonesia. And I think it's a reminder about the need to think carefully about information giving and receiving in a VA interview. This is a picture of a VA interview with the interviewer in the foreground, and it's, as I say, a bit of a reminder of it's often a group interview at different times. It's not our sort of Western ideas of a medical consultation that's one-to-one, confidential and private. And as we think about, going back to Ed's talk, about having the potential to feed back cause of death conclusions at the time of interview, those things need to be thought through quite carefully. Anyway, probably to Peter's irritation, I've always had a bit of a social view of verbal autopsy, as we've heard already, VA being a method to determine the medical causes of death for people who die outside facilities and or without proper registration. So VA, by virtue of the deaths it investigates, is about people who don't connect to health systems. And by extension, is also an opportunity potentially to examine social exclusion from access to health and health systems. And in the context of the methodological transition of the technique, there may be an opportunity to do this routinely. So on that basis, and inspired and influenced very heavily by Karen Schallender and Henry Coulter's work on social autopsy, and going back to Peter's comment this morning about perhaps occupying the middle ground between the world of social autopsy and the world of verbal autopsy. In 2010, we developed a set of 10 key indicators around circumstances of mortality to try to get to critical, limiting circumstances and events at and around the time of death that may be modifiable, may be important information for health planning. We arranged these according to a care pathway, recognition of conditions, doubts in the home, use of traditional medicine, issues of access, whether telephones and calls were made for help, whether motorised transport was used, around the geographical and financial accessibility of care, and then around quality. It might be slightly counterintuitive, but there can still be many barriers within facilities. And these 10 indicators were added to the International VA standard in 2012, and we're just starting to get now some data from them, and we're trying to figure out what might be a useful way to produce that or analyse and interpret that data. So we've just published the first paper looking at what these 10 indicators can tell us on the International VA standard. And there's a paper available if people are interested in more. But I thought I'd just share one result from that. So this chart comes from verbal autopsies done in the South African DSS that we worked on up in the northeast. In 2012 and 2013, total about 1,200 deaths. And all the VAs had those 10 indicators on them. These are the proportion of respondents that reported problems, the care pathways in the reverse order here. And this is about the proportion of respondents reporting problems in the home, on the road, and in facilities, if you like. So we saw clear problems with access. About a third of respondents for adult deaths, middle age, and elder deaths reported not calling for help, not going to a facility, and that the overall cost of care were problematic. And it's not hard to see how they might reinforce one another. So something probably going on there with traditional medicine. That's not particularly new. It's well documented how pervasive the use of traditional medicine is in this setting. But what made us scratch our heads a bit was that comparatively, and indeed in some age categories and for some particular causes, there were lower or no problems with quality of care. Now that's not really consistent with a large amount of published and anecdotal evidence about serious problems with quality. And we started to wonder, well, does a VA respondent experience access in a much more direct way than they do issues of quality? Well, possibly. So we wondered, could this possibly be a false negative here? We were reassured that the indicators were telling us something useful about access, particularly because they varied by medical cause of death. So for chronic conditions, and as you can see here in these age groups, there was this sort of three-spike pattern. For acute conditions, younger age groups, the cost just fell away, but not calling for help and not going to care doubled. So we could see some clear patterns there. So then in the second phase, we took, as I said, this longitudinal VA data from a health surveillance site, and we used it as the basis of a participatory process. We worked in 3 villages in the Agincourt site over a series of 8 weeks, preceded by some pilot work of the same sort of length and sequence. And we would go every week, same time, same place, to the village, show up with the VA data, and have a discussion about what the causes were from a more local point of view. And that was really inspired by being involved with the Alliance for Health Policy and Systems Research at WHO, who published this reader on participatory action research in 2012. And it very much subscribes to alternative paradigm, ideas of knowledge as transformatory. PAR and participatory methodologies are about shifting and balancing power during the research process to those most directly affected by the problems under investigation. And it seemed quite an appropriate thing to do with VA if we can consider VA as a way to look at social exclusion, an approach that promotes inclusion. In one of the villages, we worked with a technique called photo voice, where all the participants were given digital cameras and asked to take images of their physical environments as an input to the discussions. So again, this work mostly methodological, but I've got some results to share. When we asked communities about what, from their point of view, were the causes of under 5 mortality, we got classic social determinants of health stuff. This is nothing new. I think what is new, perhaps, is the direct reproduction of people's perspectives and realities in a way, perhaps surveying, conventional epidemiological stuff just does differently. Another cause of under 5 mortality that we were told about several times was neglect, and there was quite clear blame within and between the villages that we worked in, directed towards young mothers, particularly single mothers, around the neglect of their children. And that was slightly paradoxical in that there was a simultaneous acknowledgement of a host of social, systems, structural problems, but young mothers still seemed to be to blame. We scoured the transcripts of the interviews for expressions of blame and negativity towards estranged or single fathers, and there were none. With the photo voice, our participants didn't take images of facilities or providers, and I think that's a methodological point we need to think through. But in the discussions that we had, our suspicions around the VA data and the potential false negative with the quality of care were confirmed a little bit, in that there were repeated expressions of problems with care in terms of overcrowded clinics, long waiting times, delays with medications, delays with treatment, a pervasive lack of confidentiality, particularly around HIV status. And again, it was quite interesting that despite the acknowledgement of large systems factors, there was a lot of blame and negativity towards nurses, comparatively not much towards doctors, despite, again, the lack of autonomy that they had to control any of these systems issues and how they limited the quality of care that they could reasonably provide. So then in the third phase, we'd done this all the way through and consulted with a panel of provincial planners in the Department of Health in Mpumalanga province, as I say, all the way through. But at the end, we formally took the VA data, the PAR data, and worked with the provincial stakeholders to interpret the data, identify actions, and critique the method. And this is what we came up with. I think they're interesting in that they represent to me quite a continuum of action, from low-cost and no-cost reorganisation of existing services to more substantial changes. And one of those that I found quite interesting was to go beyond the clinic. One of the provincial stakeholders remarked that problems with housing and problems with sanitation, they are not the remit of the Department of Health, but the Department of Health bears the consequences. So perhaps if we continue with processes like this, it's an intersectoral planning that we need. In terms of the method, the provincial stakeholders liked it. They very much liked being invited into the research process and remarked that they often felt research was a luxury and not something for them and not something done by and with them. So that participatory approach in the health system, if you like, was well received. They particularly also liked the combination of the longitudinal data with the visual data. The quantitative and the qualitative seemed to produce quite compelling and powerful evidence for them. So that's where we are. We have this methodology now, an HSR, health systems research method. I think it's possible to be both based on core international standards, the VA, and with techniques like social autopsy and participatory research, there are ways to also do justice contextually. We've developed some new ways to understand deaths in VA. We've been able to look at underlying mechanisms, norms, etc., with the PAR, and obviously embedded the process in the health system, or attempted to throughout. I think the co-produced evidence and going through those steps of interpreting with the VA, then interpreting in communities, interpreting data in the health system helps strengthen not only renditions of complex problems, but ideas about what to do as a result. And for me, one of the really important outputs from this work are the partnerships. And what we're currently doing is planning to extend the process to start to plan and act. If you like, we've probably been through the yellow observe and blue analyze part. And I think now to start to get into cycles whereby issues are examined, actions are identified, and then implemented and re-evaluated in an ongoing cycle as a way towards sustaining and supporting positive change. There's some papers out at the moment and some articles in the conversation, so it just leaves to acknowledge my funders. Thank you very much.